For a systematic review of pelvic pathology, we look to the established academic foundation of clinical gynecology to define the mechanisms of endometriosis. This diagram distinguishes the myometrium, the uterine muscular wall, from the surrounding pelvic spaces. While adenomyosis is confined to that wall, endometriosis involves tissue migrating outside the uterus entirely into the peritoneal cavity. Even with modern imaging, clinicians still face a persistent ambiguity regarding the disease's origins. We observe the lesions, but the exact pathogenesis remains a matter of ongoing study. The most widely recognized model in medical literature is the classic theory, first proposed by John Sampson. Sampson's theory identifies retrograde menstruation as the primary vehicle, where menstrual material flows backward through the fallopian tubes. Following this reflux, endometrial cells adhere to ectopic sites. This process of implantation occurs primarily on the ovaries and the pelvic peritoneum. For these misplaced cells to survive and proliferate, they must establish a localized blood supply and adapt to the unique biological environment outside the uterus. While the classic theory provides a mechanical explanation for cellular movement, the resulting clinical condition involves a series of complex inflammatory and anatomical changes. Infertility is the most frequent clinical consequence of these changes, affecting a high percentage of patients diagnosed with the condition. Clinical assessments often reveal patients with fully patent fallopian tubes and intact anatomical structures who still remain unable to conceive. This lack of success occurs because infertility in these cases is strictly a multifactorial state, involving more than just physical barriers. To manage this effectively, we must map the 5 distinct pathophysiological pillars that prevent successful reproduction. The foundational text identifies 5 factors that disrupt the reproductive process, ranging from chemical signals to physical obstructions. These factors operate across molecular, immunological, and mechanical domains, often affecting the patient simultaneously. Understanding this allows the physician to treat the patient for systemic pelvic toxicity rather than searching for a single mechanical fault. The first major factor is a toxic pelvic environment, where the peritoneal fluid neutralizes gametes and prevents fertilization. The second pillar involves the overproduction of prostaglandins by ectopic lesions, as represented in this molecular diagram. These prostaglandins impair the fallopian tube's peristaltic motility, creating erratic muscular contractions that disrupt the transport of gametes. This biochemical flood also inhibits follicular development and disrupts the normal function of the corpus luteum in the ovary. These chemical alterations create a primary barrier that prevents fertilization, even when the patient's anatomy appears healthy under examination. The third factor involves immunological alterations, specifically the hyperactivation of macrophages and the secretion of numerous pro-inflammatory signaling cytokines. Chronic inflammation creates a localized state of immune surveillance that actively selects against fertility within the pelvic cavity. The fourth pillar is the disruption of the ovulatory cycle, which impairs follicular growth and prevents the follicle from rupturing. This inflammatory environment also exerts a negative effect on the development and health of the fertilized ovum. This immunological pillar explains why patients with clinically mild disease face infertility rates similar to those with extensive physical scarring. The fifth factor is the mechanical obstruction caused by the development of pelvic adhesions. These fibrous bands form as the body attempts to isolate areas of chronic inflammation, tethering organs together. Adhesions physically distort the space between the fimbriae and the ovary, making it impossible for the tube to capture the egg. Unlike the biochemical factors, mechanical obstruction can be visually identified and physically addressed by a surgeon. These 5 pillars combine to create a significant biological filter that requires a strategically divided approach to therapy. Management must be tailored to the patient's goals, since no single treatment provides a complete cure. For patients whose priority is quality of life rather than immediate conception, we use a medical suppression pathway to manage pain. The clinical regimens for pain include progestins, oral contraceptives, danazol, and GnRH analogs. These treatments induce systemic remission by silencing the inflammatory signals produced by ectopic tissue. Physicians should note that symptoms typically return after therapy ends, as the ectopic tissue is suppressed but not eliminated. Medical suppression is incompatible with active fertility efforts because it halts the very ovulatory processes needed for pregnancy. Surgery is the chosen pathway for patients seeking pregnancy or for those with endometriomas that do not respond to medication. The surgical objectives are clear: the destruction of visible foci, meticulous removal of adhesions, and the excision of cysts. During these procedures, the surgeon must adhere to a critical rule: the preservation of all active ovarian tissue. Aggressive surgical removal of cyst walls can inadvertently destroy the primary ovarian reserve by stripping away the vital adjacent healthy follicles. Tissue preservation is essential, as it dictates the patient's future chances for natural conception and the success of assisted reproduction. IVF remains the final option for severe cases because it physically bypasses the biological barriers present in the pelvic cavity. The modern gynecologist must balance the thorough eradication of the disease with a conservative, protective approach to the patient's reproductive future.